Good afternoon, ladies and gentlemen. Welcome to this new webinar series in androgen excess in women. During the next few months, one of the most prestigious doctors and professionals will talk about different topics on this area. Today, for our first webinar, we have with us Professor Johannes Bitzer from Switzerland with the topics androgen excess in women and endocrine. So please, Professor Bitzer, when you want, you can start with your presentation. Everyone is seeing you through the webcam.
Yes, good afternoon, dear colleagues. Thanks for taking part in this webinar. I would like to give you an overview about the issue androgens in women, endocrine, and clinical overview. This is just a brief agenda. We will first look into the definition and manifestations of this condition of androgen excess, then into the main clinical pictures of acne, hirsutism, and finally PCO, and then I will try to give you a summary. Now, androgen excess is a complicated issue because it consists of different entities. One is what we call the clinical hyperandrogenism, where you have not necessarily or usually no elevated androgens, but there is an increased sensitivity to normal serum androgen levels by the pilosebaceous unit, so by the unit which is responsible for sebum production and also for hair growth to a certain degree. And this can cause hyperandrogenic symptoms because of increased sensitivity even to normal levels of androgen. Then we have the biochemical hyperandrogenism, where there is excessive production and or secretion of androgens. And these androgens, as you all know, may be of ovarian or adrenal origin. I'm coming back to this in a minute. And in quite a considerable number of patients, both conditions are together. So there is elevated androgens on one side and also increased sensitivity of the skin and the hair. Now, very brief to remind you, where do androgens come from in women? The sources are ovary and the adrenals, and the peripheral transformation of those substances which are produced by the ovary and by the adrenal. And this peripheral transformation of these substances into testosterone makes up a huge amount of the most active androgen, which is testosterone or DHTA. So what is it? Is it worthwhile to talk about this condition? It is, because androgen excess is the most common reproductive endocrine disorder in women. It affects up to 1 in 5 women of reproductive age. And I'm coming back to this a little bit later. The majority of women with androgen excess, up to 80 to 85%, also have polycystic ovary syndrome. What is the manifestation? We've talked about prevalence, now let's talk about manifestation. The manifestation is any combination of hyperandrogenic skin symptoms, seborrhea, acne, hirsutism, alopecia, with or without menstrual irregularities, with or without a problem of infertility. So now let's first talk about this condition which is called acne. Hyperandrogenic skin symptoms, very frequently, of course, combined with seborrhea. I think it is important to understand that acne is not just a cosmetic problem. It's a medical and socioeconomic problem. It's the most common disease of the adolescent age. It's the leading dermatological diagnosis and one of the most common overall diagnoses in general practice, also in dermatological practice. It's a costly disease, and there has been economic studies indicating that acne treatment amounts to 18% of the overall worldwide costs for the treatment of skin disease. It is also important to understand that it is a chronic disease. Of course, it manifests itself mainly in adolescence, and adolescents suffer the most from the condition. But we must not forget that acne can also start at a later age. Look at here, about 25% of women suffering from acne, the disease actually starts at the age 20 to 25 or more than 25. And it's a lifelong disease, and it's a chronic disease. We all know that the manifestations are different, and here I think a close collaboration between gynecologists and dermatologists is necessary. The basic mechanism, of course, is the increased sebum production and altered keratinization and hair growth, which is stimulated by androgens. And the other pathogenetic condition necessary is the inflammation and bacterial colonization by Propionibacterium acnes of hair follicles on the face, neck, chest, and back. And we have to understand that for clinical reasons, for treatment decisions, it is important to differentiate between comedonal acne, which is the presence of open or closed comedones, a papillopustular acne, where you have the presence of non-inflammatory and partially inflammatory lesions that may be either superficial or develop into deep pustules or nodules in more severe disease. And then we have the nodular acne, which is the presence of small nodules that are painful by palpation, or large nodules which may go over larger areas and also can result in painful lesion, exudative sinus tracts, and tissue destruction. And I think we all agree that this is a condition which needs multidisciplinary approach together between gynecologists and dermatologists. Now, as I mentioned before, what is really the suffering of these patients? There have been very good studies looking into the emotional effects of acne, and as you can see that in fact it has a negative effect on self-esteem, self-confidence, self-image, and also a certain mental health morbidity. We do find depression and anxiety in studies, and even in study, suicidal ideation has been reported. Of course, with the severe conditions, but the individual suffering does not necessarily correspond to what you find so-called objectively. I'm coming back to this a little bit later when we talk about the treatment. So I said, if you want to understand the disease, it's inflammation, altered keratinization, follicular colonization, but the role of androgens is that it induces increased sebum production and hair growth. It is a multifactorial disease, as mentioned before, also regarding risk factors contributing to the disease. We have non-hormonal influences like genetic predisposition, medication use, cosmetics, competitive sport, lifestyle aspects, pressure or friction on the skin, and we have hormonal influences which may be related to the menstrual cycle, of course to PCOS, to androgen excess, as I mentioned before, and also to certain hormonal contraceptives. I'm coming back to this a little bit later. Again, to make you aware of the importance of this disease, which is frequently just considered as a smaller cosmetic problem, Professor Tsoubulis has published this very nicely and compared acne to atopic dermatitis, which is acknowledged as a chronic skin disease, that there are very common characteristics which are true for both diseases, meaning that acne also can be considered as a chronic inflammatory skin disease. So what are the principles of management in acne? I think it is really important. Most acne patients do not need further investigations from an endocrine point of view. As I mentioned before, most of these patients, if it's not in the condition of PCO, and I'm coming back to this a little bit later, do not have elevated androgens. So the basic care is skin hygiene, counseling and support, and that we try to have a rational approach to these conditions. I think it is important that we dispel myths about treatment risks, and also about duration of treatment. There is a long list of possible treatment options for acne, which are basically based on reducing production of sebum, decreasing skin bacteria, but also very important, decreasing the effects of androgens. As you can see, androgen receptor antagonism in flutamide and spironolactone, and finasteride, for example, which suppresses overall androgen activity. All the different approaches have to be seen also regarding their side effects, and have to be valued in the context also of their side effects in the decision. Now, the treatment options, if you look at guidelines and if you look at publications, we can still say that COCs containing low or anti-androgenic progestins have the highest level of evidence regarding the efficacy. Addition of spironolactone, flutamide, metformin are other possible approaches which have a lower level of evidence regarding efficacy. Why is a combined hormonal contraceptive efficient? There are different mechanisms at the same time which play together. Ethinylestradiol increases SHBG, reduces free testosterone. Ethinylestradiol plus progestogen inhibits FSH and LH secretion, thus reducing ovarian and androgen production. Then anti-androgenic progestogens act as competitive inhibitors at the androgen receptor level, and certain anti-androgenic progestogens inhibit 5-alpha reductase. So you have these four mechanisms of action which make combined hormonal contraceptive, especially with an anti-androgenic progestogen, useful. And as you know, we have different anti-androgenic progestogens, which are cyproterone acetate, chlormadinol acetate, dienogestin, drospirenone. Here they are summarized. You all certainly know about them, and you know that as far as anti-androgenic potency is concerned, cyproterone seems to be in the studies the most efficient anti-androgenic progestogen. There have been a considerable number of studies showing that, in fact, for example, combination with CPA in the form of Diane is effective in reducing the disease and achieving even a complete clear-up of facial acne by months of treatment. Again, you can see that you have a response already after 3 months if I take severe acne here, but that to come to a full response, you need longer treatment. My final important message is that we really should work together with this to help these women with this condition, that we really have a close collaboration with the dermatologists. Now I come to the other condition, which is hirsutism. What do we know about the prevalence of hirsutism, which is where there is a regional difference? It is, as you know, the presence of excess body or facial terminal hair growth in females in a male-like pattern. It's not just more hair, but it's the male-like pattern which is important. And it usually reflects the interaction between circulating and local androgen concentrations and the sensitivity of the hair follicle to these androgens. Now, the reported prevalence varies, as you know, according to ethnicity. It seems that women in Far East Asia present less frequently hirsutism. I think what is important, hirsutism can be the leading symptoms in women with really hyperandrogenemia, mostly associated with PCOS. So here the issue is really elevated androgens. Again, the impact can be very severe regarding quality of life, which we can imagine, and I think which we all know from our clinical practice. How to quantify it? I think there is still a modified Fermin-Galway score, which is considered to be the most objective way trying to quantify, which of course is usually done in clinical trials, but which also of course may help you in the consultation together with the patient to follow up the treatment and manifest treatment improvement. And as you can see, this sums up to a certain score. And it is said, if I may come back to this a moment, that a score of above 8 is considered to be really significant and also a significant sign of possible PCO. If we go into the etiology of hirsutism, of course, the hyperandrogenism may come from the adrenals, from the ovaries, or from central endocrine dysregulation. And in this publication by Body, you can see that if you go into the possible background conditions, you see that the most frequent condition is actually PCO, followed by idiopathic hyperandrogenism, idiopathic hirsutism, non-classical congenital adrenal hyperplasia with elevated 17-hydroxyprogesterone and androgen-secreting tumors. So this, in fact, brings me to the point that if we have really hyperandrogenism with elevated androgens, we have to be aware of different clinical conditions which have to be differentiated, especially if we have a patient with clinical features of androgen-secreting tumor, which usually is the sudden rapid onset of hair growth, severe hirsutism, obvious signs of virilization, clitoridal enlargement, and maybe palpable abdominal or pelvic mass. And also, you know, just to have sort of a short guidance is if you have a total serum total testosterone level of more than 4 nanomole per liter, really look into the possible tumor formation or elevated 17-hydroxyprogesterone levels, look into the adrenal condition. So there are different approaches to treat hirsutism. You have the treatment which goes directly to the skin and the hair, the laser treatment, the cosmetic treatment, eflornithine hydrochloride cream. You have the anti-androgens alone, and you have the anti-androgenic progestogens in combination with exogenous estrogen, which is combined oral contraceptives with an anti-androgenic progestogen. And again, here the treatment of choice is actually in those women who do not want to get pregnant, because the use of combined hormone treatment, because it can achieve a decrease in serum androgen levels and subjective improvement in hirsutism. Of course, again, you would probably choose the most potent anti-androgenic progestogen because this is the most valuable for achieving a therapeutic improvement. And again, it is very important to understand that treating hirsutism is a long-term treatment where you need many cycles really to achieve a considerable improvement in the reduction of the Fermin-Galway score, as you can see. As you can see here, after 48 cycles, you had a 72% reduction in the initial Fermin-Galway score. And now I come to my last part, where somehow all these conditions are present at the same time. And this is, of course, polycystic ovary syndrome. As you probably all know, the Rotterdam criteria define PCOS by the presence of 2 of the following conditions after exclusion of other androgen excess or related disorders, as I mentioned before. So the three conditions where you have two of them present to diagnose PCOS is irregular menses, hyperandrogenism, either clinical or biochemical, and polycystic ovary morphology in the ultrasound. Again, regarding prevalence, it is different in different parts of the world, but it is present all over the world actually as an important frequent condition. Laboratory findings to help you differentiate if is total testosterone, 17-hydroxyprogesterone, the FSH-LH ratio, and estradiol levels. And in ultrasound, the definitions are 8 follicles at the periphery of the left ovary, maximal diameter of 10, 8 follicles at the periphery of the right ovary, maximal diameter 13 millimeters. And of course, no indication of endometrial hyperplasia, which may be the reason for the menstrual irregularity. Now, what is very important is that PCOS is again a disease which demands a multidisciplinary view, because it's not only about skin and about cycle, but it's also about metabolic and reproductive risks. As you can see here, cardiovascular disease, endometrial cancer, infertility, menstrual dysfunction, type 2 diabetes, and insulin resistance. And I think it is important to understand that the manifestations may be really different at different age, at a different age. With increasing age, there is a change in presenting symptoms and health complications. It may start with skin, with menstrual dysfunction, infertility problem, but then it goes, of course, in aspects which are important for later life, like insulin-resistant type 2 diabetes, dyslipidemia, cardiovascular disease, and cancer risk. So this is why this condition is so important. Regarding these long-term risks, there is some possibility a little bit to evaluate the long-term risks. Those with the phenotype A and B are at greatest risk for metabolic dysfunction. Here you can see hyperandrogenism, ovulatory dysfunction, polycystic ovarian morphology. And as you can see, if the full-blown picture, phenotype A, or the picture with hyperandrogenism and ovulatory dysfunction, they seem to have the highest risk regarding these long-term metabolic dysfunction I was talking about. As I mentioned before, we should have a comprehensive approach to these patients. We really should have a look at the metabolic impact of the condition. As you can see, these are the possible further investigation. Now, it is a disease which affects different organ systems, but it is certainly a disease where androgens play an important role, and this is why anti-androgen therapy is important. It is still considered that a combination of ethinyl estradiol with a progesterone that possesses anti-androgenic activity is regarded as the most appropriate choice for treatment in PCOS in women who do not want to get pregnant. As I mentioned before, the mechanisms are in fact that you increase SHBG, you reduce androgen synthesis, you decrease adrenal androgen synthesis, and you reduce DHT binding to androgen receptors. Again, as I mentioned before, the anti-androgenic potential is different, and you would have to decide according to the individual patient which combination you use. These are my final slides, because I think in clinical practice we have to find the right balance in women with PCO who do not want to get pregnant. We're not talking about infertility today, because on one hand we want to have the efficacy of the treatment of hyperandrogenic skin symptoms and menstrual irregularities. We want to prevent long-term metabolic and neoplastic risks. And if possible, we want to maintain or even enhance fertility. And I think certainly lifestyle modification, weight reduction, exercise are very important, of course, especially for the prevention of long-term metabolic risks. They are less efficient, but there is some impact, or there have been some studies showing that it also leads to an improvement in skin symptoms, and metformin has also been shown to may have a positive effect of preventing long-term negative metabolic effects. The other issue is the other core treatment, of course, is the combination of ethinyl estradiol plus anti-androgenic progestogen. This treatment is very effective according to the anti-androgenic potency in the treatment of hyperandrogenic skin symptoms and menstrual irregularities. It regularizes the cycle, it reduces irregular bleeding, it reduces heavy menstrual bleeding. There are some positive effects regarding neoplastic risks, especially endometrial carcinoma, as we know that it protects against endometrial carcinoma. And there is some not yet well demonstrated evidence that it may maintain and enhance fertility in the future. And these effective treatment actions have, of course, to be balanced to the cardiovascular risk, which is associated with this, to the cardiovascular risk which is associated with this treatment. As you all know, there is an increased VTE risk, which seems to be slightly more in those combinations where you have anti-androgenic progestogens. So my final recommendation or my final call to action is actually that if you find one androgen sign, look for more and act multidisciplinary. This is a condition where we very often have dermatology, we have gynecology. You know, in dermatology, we have acne, oily skin, alopecia, hirsutism, seborrhea. In gynecology, we have menstrual irregularity, infertility, fibrocystic breasts, endometrial hyperplasia, ovarian enlargement, PCOS. And internal medicine, we may then find android obesity, hypertension, insulin resistance, diabetes, lipid abnormality, and also in some cases, adrenal hyperplasia. So thank you very much for your attention, and I'm open for questions now.
Thank you very much, Professor Bitzer. We will see you later again after the next activity. So as we mentioned, we continue with the next activity in this webinar on androgen excess in women. And before to start with the polls, that is the name of the next activity, I would like to remind our attendees that if you have some questions for Professor Bitzer, you can use the question function that you will find in your control panel. So for this activity, you will see on your screen a question with multiple answers, and you need to answer the one that you think that is correct. And after that, we will read the results between the audience. So here is the first question. Here are the results from our first question today. Which of the following statements regarding androgen excess in women is not correct? 25% of our attendees answered the option A. Most patients with acne do not have elevated androgens. 45% of our attendees answered the option B. The pilosebaceous gland is more sensitive to androgens in biochemical hyperandrogenism. 10% of our attendees answered the option C. Androgen excess affects up to 1 of 5 women of reproductive age. And 20% of our attendees, answered the option D. 80% of women with androgen excess have a PCO. In this case, the correct answer was the option B. Here is the second question today. Here are the results for our second question today. Regarding hyperandrogenic skin symptoms, which of the following statements is true? 5% of our attendees answered the option A. Acne affects 50% of adolescents, doesn't start newly at all the age. 48% of our attendees answered the option B. Increased sebum production facilitating follicle colonization by Prof. 38% of our attendees answered the option C. Severe nodular acne is effectively treated by anti-androgens. And 10% of our attendees answered the option D. Clitoris enlargement is typical symptom of idiopathic hirsutism. In this case, the correct answer, it was the option B. And we continue with our last question today. Here are the results from our third and last question today. In a 20-year-old patient presenting with irregular menstrual pattern and moderate facial acne, which of the following diagnosis is correct? 85% of our attendees answered the option A, PCO syndrome. There were no answers for the option B, hypertrichosis. 15% of our attendees answered the option C, adolescent acne, and there were also no answers for the option D, hypothyroidism. So we continue with the next activity that we have received some questions from our attendees. So in order to everyone to follow and to read the question, you will receive through the chat function, and briefly we will see again Professor Bitzer Good afternoon again, Professor Bitzer. So here is the first question that is coming from our attendees, from Angela Juby. Can you comment on the use of androgens in HRT in postmenopausal women? Thank you.
Well, here you are touching the issue that in some postmenopausal women, due to the low levels of androgens, because androgens decrease starting at the age of 30 or 35 continuously, that these women may suffer from lack of androgen, not androgen excess, but lack of androgen. And here we know that the addition of androgens in these women who frequently present with low sexual desire or also some depressed mood symptoms, that the addition of androgens, for example, we had the testosterone patch, or we have the combination in Tibolone, where you have an androgenic metabolite, that these may indeed have a positive therapeutic effect. But these are women suffering from not enough androgens, not from hyperandrogenism.
Thank you very much, Professor Bitzer. We continue with the next question from our attendees. It's coming from Jano Santa. If a woman does not want to get pregnant and denies COC, what is the second best choice?
You mean in a woman with androgen excess, probably, that is the question. Yes, I think what I would not so much recommend actually would be, or let me put it the other way, the most efficient contraception then is, of course, using LARCs, long-acting reversible contraception. And in these patients, probably the copper IUD would be best. We do not know very well about the effects of progesterone long-term contraception on the tolerability, but there is some indication that you may increase negative skin symptoms with LARCs, long-acting hormonal contraceptive based on progestogens. So in this case, the best prevention of pregnancy would probably be, in my view, be the copper IUD.
Thank you very much for your answer, Professor.
If I may add one thing. If you have, of course, the patient with hyperandrogenic skin symptoms and heavy menstrual bleeding, then you have to balance it again, because, as you know, copper IUD, of course, may even increase the bleeding. So this may then be a patient where you may think of LNG IUD, balancing a little bit the risk that you may at least certainly not improve, but even not ameliorate skin symptoms. So here you have to balance between skin symptoms and bleeding problems, if it is heavy menstrual bleeding. Yeah.
Thank you very much. So we continue with the next question that is coming from Kalani Kahapola. Can you please comment on hypertrichosis of ovary as a cause of hyperandrogenism?
Yes, I didn't mention that because it's a rather a rare condition, but you are right that the androgens actually come from the ovarian stroma, and that you have conditions with overgrowth of ovarian stroma, and then you have this condition where you have this androgen excess, which is then really caused mainly by this stromal production of androgens. Of course, these patients very often have not only anovulation but amenorrhea, and you may have then to go further in your diagnosis of the ovarian origin of this hyperandrogenism.
Thank Thank you very much. We have one more question that is coming from Maria del Carmen Cravioto. Could you comment on TIV risk among EE cyproterone acetate formulation?
Yes, this is the opinion at the moment, which is also formulated and documented by the European Medical Agency, is that the combination of EE and CPA belongs to the so-called third and fourth generation progestogen combined oral contraceptives, which have double the risk of those combinations with LNG and NETA. In absolute numbers, what the EMAS says is that if you have 4 to 8 in 10,000 women developing a deep venous thrombosis with an LNG pill, you will have 8 to 12 or 6 to 12 in those who use one of the combined preparations with anti-androgenic progestins. Whether CPA is more than the other anti-androgenic progestogens is very controversial. Some studies indicate that it has a slightly higher risk than the other ones. Others did not find this increased risk. So I think for the moment, the general statement is that you have a slightly increased risk compared to a second generation pill, but the absolute numbers, as I mentioned before, are still low, which is the reason why the European medical authorities came to the decision that the EE-CPA combination should not be withdrawn from the market. Maybe you remember that the French authorities were applying that Diane, in this case, should be taken out from the market. But thorough evaluation of the European Medical Agency found that the benefit-risk ratio is still valuable for this combination. The labeling, however, as you may know, is that the combination EE-CPA should only be used in women with moderate to severe acne needing contraception. So it is not a contraceptive of basic contraception, but it has to be used in the context of hyperandrogenic skin symptoms or hyperandrogenism. This is now a clear statement in the label.
Thank you very much, Professor Bitzer, for your answer. Looks like that our attendees don't have more questions. So thank you very much for your time, for being together with us. And we hope to see you soon. And also thank you very much to our attendees for joining this first webinar on androgen excess. That this initiative, it was initiated by the European Menopause and Andropause Society together with the European Society on Contraception and Reproductive Health. So we invite you to visit onlineeducation.eu in order to register and to follow the next speakers. But before to finish, we have Professor Bitzer, one last question that arrived just now. It's coming from Julio Mayorga. Is any clinical significantly difference on Ferryman scale scores between PCO with anti-androgenesis effects and no anti-androgenesis progestins?
Yes. Yeah, well, actually, the studies, there are no comparative studies regarding treatment of hirsutism, like where you would compare an LNG pill with a CPA pill, because obviously nobody was convinced that a pure, a pill with a non-anti-androgenic progestin would be able to improve hirsutism considerably, because hirsutism, as I mentioned before, needs a rather strong anti-androgenic action and a long-term anti-androgenic action. But there are no comparative studies, so the studies are actually done with combined preparations with anti-androgenic properties, at least to my knowledge. And I've gone into the literature of the efficacy studies. This is not, if I may add, this is not true for acne. There are studies indicating that mild acne can be treated with a combination of EE and LNG, probably due to the effect of EE and the elevation of SHBG, which is small in these preparations, but obviously in some women it may lead to a diminution. But on the other hand, we also know that one of the rather frequent side effects of EE LNG pill may be the new occurrence of acne.
Perfect. Thank you very much. Now looks like that it was the last question finally. So we are very happy to announce that this session is being recorded, and it will be announced soon when we'll be able to watch offline. So thank you very much once again to everyone, to our attendees, to Professor Bitzer for a fantastic speech, and we hope to see you soon. Wishing you a great day.
Bye-bye. Have a good day.